Okay, good afternoon, folks. Hello, wherever you're coming from. Welcome to another webinar from the Steps Forward Innovation Academy. Today, we'll unpack the 2024 national findings from the AMA's Organizational Biopsy Wellbeing Assessment Tool, drawing on responses from over 30,000 physicians, advanced practice providers, and residents across 100 healthcare organizations, over 100 healthcare organizations. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult with a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. And let's just take a moment here to go over your experience today as an attendee. If you are joining us on Zoom, you will see a dark menu bar either at the bottom or top of your window. There you can access a selection of resources related to our webinar today, including links to learn more about the Organizational Biopsy Tool and the AMA's Joy in Medicine Recognition Program. There's also a link to stepsforward.org where you can find all of our past content and what we have in store for you later this year. If you don't see these options, select the three-dot More button on that dark bar to access the resources and Q&A. And if you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom so that you can access the resources and ask questions for our speakers to answer later. After our webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the Resources tab to the AMA EdHub and claim the credit there. Also in the resources, you will see a link to our upcoming webinars. Check out the programming we have planned for the rest of the year and register there all in one step. I'll be sure to remind you of all this at the end. For now, I would like to introduce you to today's speakers. We have Dr. Jane Fogg, the Physician Director of Organizational Transformation here at the American Medical Association, and I'm about to pass it to Nancy Nankivil, the Director of Practice Transformation here at the AMA. Nancy, go for it.
Great. Thank you so much, Alex. That was a great welcome, and I want to extend our welcome to everybody that's joining us today. We're going to be talking today specifically about our work in organizational well-being, and in fact, we're going to be drilling down deep into our data that, as Alex shared, comes through our work with 100 plus health systems on an annual basis. So our learning objectives today is for you to gain some familiarity with our AMA efforts in this space. And as I mentioned, Dr. Fogg and I will be commenting on data to give you more and more information on the state of well-being. And then we want to make sure that we have time so that you can share your questions, your feedbacks, anything that is useful to you post this session. And we're here as an ongoing resource. So my job today is to set us up with a little bit of level setting. So Alec, we can move to the next slide. Our work in organizational well-being, or in particular our measurement work through the organizational biopsy, is something that we've been focusing on for almost a handful of years. And so we have been accumulating data through a particular survey instrument, working with, again, hundreds of healthcare organizations across that time. And what we're going to be showing you today are the key findings from our 2024 National Physician Comparison. Next slide, Alex. In our work that we do in the organizational biopsy, we are focused on getting to the system drivers of well-being. So we're not only focused on resiliency or how individuals are caring for their own well-being, we are looking at that 80% of impact that can be, and many of our organizations are leaning into this, driving it from a system level. And so at the core of our assessment work, we have 10 health system drivers that we are measuring, and then the organizational biopsy allows organizations to drive deeper into the various domains that you're seeing in purple. What's happening in their culture with regard to leadership, teamwork, trust? How is practice efficiency or inefficiency impacting their physicians and clinicians? Things like team structure, but also the use of the electronic health record, documentation time. We're now beginning to study the impact of AI on the well-being and workload and workflow of clinicians. Self-care, as we mentioned, including work-life balance, time off and its impact, and how organizations can lead and build on peer support. And then as important is the retention issue. Do we have clinicians that are giving us signals that they may be leaving their organization in the next 2 years? Do we have signals of physicians and clinicians beginning to reduce their time in direct patient care to something less, possibly due to administrative burden? So this survey tool, which again is a part of our mission work and offered free of charge to organizations, really builds a database that we sit on and can do longitudinal research as well as provide that information back to healthcare organizations, giving them comparison data. Next slide. As I mentioned, we are going to be looking specifically today at our national comparison for physicians from the 2024 data that we accumulated through this body of work. So a little bit about where this data set is coming from. You will see it includes all data that we collected from about 105 healthcare organizations from January 1st through December 31st of 2024. This body of responses includes just under 20,000 responses coming directly from physicians, and then just under 10,000 responses that came directly from APPs. And we do segment that data by role type because we do see differences that are important as organizations look at their policies, look at their intervention opportunities and improvement opportunities. Many of our organizations are coming throughout the national landscape. We have a couple of areas in white where we have no representation at this time, but we would love to work with organizations that might be from those various states. We can filter our data not only on some of the demographics that Dr. Fogg will be taking you through, but by regions in the country. So we can see if there are other systemic type issues that might be driving healthcare in certain geographic areas, as well as other various organizational demographics. Many of you might be familiar with our Joy in Medicine Health System Recognition Program. We do have a good group of organizations that both measure through us as well as support their efforts through our recognition program. And I know that we'll have resources that you can link to representing our organizational biopsy, which is where we'll focus our time today on the data, as well as our Joy in Medicine Health System Recognition Program. So with that bit of level setting, I'm going to turn this over to Dr. Fogg, who will take you through the findings from our 2024 data.
Great. Thank you so much, Nancy, and very nice to see everybody virtually. So I'm going to take you through the 2024 data and share some of our insights. It advanced. As well as some, at the end, we're going to talk a little bit about what we recommend people do after survey. So starting here, these are our key performance indicators. These are measures that we like to follow over time, that we ask organizations to consider putting on their metrics. If you go from left to right, you'll see that on the top, these are people who agree or strongly agree that their job provides satisfaction, that their job is a source of stress. In the middle, burnout, experiencing at least one symptom of burnout. For intention to leave, these are people who say definitely or moderately likely that they will intend to leave in the next 2 years. And then finally, on the far right, feeling valued by your organization. So we're looking at 2023 on the top, and you can see in the middle green, there's a good sign that year over year, we've experienced some improvement in these metrics, specifically improvement in job satisfaction, a reduction of stress. Nice to see a reduction in reported burnout down to 43.2%, and intention to leave and feeling valued also showing some improvement. But by no means do we think that we are at goal. Improvement is good, but we certainly have a long way to go. As we think about this data, it's also important to note that we're aware this is a convenient sample. And so we also like to look at other ways we've measured burnout. So the AMA, Mayo, and Stanford have conducted a burnout study every 3 years. It is a representational sample, and that has been trending in the same direction. That is also showing a decrease in burnout from 2021 to 2023. So we're trending in the same direction. So I also wanted to just show you the APP data to let you know that there's also a similar improvement across the board, as you can see. There is APPs in general have a little higher satisfaction and reduced stress, but their burnout is registering higher than physicians, their intention to leave higher, and feeling valued lower. So running along similar lines with some differences. So we also want to take a look at this over time. And so we're sharing 3 years of data here so you can see the trend lines of some of our KPIs. And on this graph, we've plotted job satisfaction, stress, and burnout. Because what we can see when we look at this over time is, first of all, these trends are going year over year. So there has been a steady improvement in burnout year over year for us, an improvement in job satisfaction. But there's also this inverse relationship. If we are more satisfied, we are less burnt out. We see that stress often parallels burnout. So we pay attention when we see an organization that has high level of stress. We are also trending here intention to leave and feeling valued. And it's interesting to note this inverse relationship. And this is one area that we find provides very rich conversation with health systems. What are the things that we can do in practice, whether it's a private practice or a large system, that improve one's sense of feeling valued? Because we know that can mitigate the effects of burnout. So we're seeing this inverse relationship and an improvement in both. We do ask physicians to report their time per week in their practice, and this is across all specialties. And they are reporting how many hours a week they spend on direct patient care, which is taking care of patients, whether you're at the bedside in the hospital or in the exam room in the office. And they also ask them how much time they're spending on indirect care. These are the things, the activities that we need to do to take care of patients, but they're not directly with the patient in the room, doing paperwork, filling out forms and such. And we also ask about some administrative burdens. What we've seen over time is there's no statistical significance in the overall amount of time reported that physicians are taking. There continues to be a relationship where for all the direct patient hours we do, for every 1 hour, about 45 minutes are spent in that indirect or administrative time. So we're watching that as well. We wanted to just show you a normal distribution here so that you can see the improvements that we're reporting are also following the normal distribution patterns. And we did burnout here as well as feeling valued. So little eye chart. So I'm going to point some things out here. One of the improvements we made in the last year is we have many, many specialties who do take this survey. And we wanted to start looking at groupings, typical groupings that we're all familiar with, the CMS categorization, primary care, hospital-based care, that would be hospitalists, emergency room radiologists, and so on, medical specialties, surgical specialties, obstetrics and gynecology, and psychiatry. And we're showing you the KPIs by those various groupings. And I'm just going to point to a few things because the first thing I always want to point to is burnout is shared by everyone. We often talk about it in primary care circles, but it's absolutely shared across the board by every specialty. And there are some areas that stick out. We see a lower level of satisfaction in our hospital-based colleagues, stress quite high in OBGYN, and we've been looking at that and thinking about that in context to all the changes from the political environment that impact care. We also see a higher level of burnout in our OBGYN colleagues. For intention to leave, surgical specialties surprisingly the highest, and feeling valued the lowest. So we like to look at these things and break them down a little bit because we know we have many different practice environments, and some of those influence our feelings and our ability to change the environment. But we do share burnout across the board, and we all have a lot of work to do in various areas. So now I want to take you through just one KPI, burnout, and this is where we use our demographics to do some slicing and to better understand what's happening. So we ask all of our participants for gender identity, racial and ethnic group, years post-training, medical specialties, and a few other things. And what I want to point out here first is that we have seen a persistent percentage point difference between female physicians and male physicians. It is a gap that was at one point 10 percentage points between male and female. It's narrowed slightly to 8, but it continues to be a persistent finding across all the groups that we work with. And so something that we've had many discussions on about what are the factors that would influence that. Similarly, when we look at the years post-training, you can see sorry, I'll go back here. You can see that there is increasing burnout in those middle years. Your first 5 years out of practice, after 20 plus years, you're faring better than those middle years. And what are the factors that might lead to that? We do report the medical specialties. Everyone always wants to know which specialty is the worst. We are careful to only include the specialties where we have a higher sample size. So these are the medical specialties that have the highest sample size, and among them, emergency medicine is at 51.2%. We do know that people often reduce their clinical full-time equivalent in order to mitigate some of the effects of burnout and of unmanageable workloads. And we certainly see that although there is an improvement for some, reducing their clinical full-time equivalent, we also know that they continue to have excessive workload despite that. And as many of you know, when you reduce your clinical hours, but you still take care of the same number of patients, you simply end up doing it in your inbox and other methods. I also want to go through the feeling valued slide here. And I think it's just interesting to note when you look at feeling valued, I pointed out that burnout was higher in female physicians, and now you're seeing that feeling valued is higher in male physicians. We also note the same inverse relationship with years post-training. Those middle years, especially 6 to 10, are reporting the lowest sense of feeling valued. So again, it gives us an idea of where we might want to look further to understand the factors that do that. Next, I'm going to move to leadership. And again, apologize for a busy slide. The reason we wanted to include this is that we've really seen and understood both from research, but also from what we are seeing across the many practices that we work with, that leadership really matters. And specifically, your immediate leader, whether that is your local medical director or the chair of a department, the person who supervises you, the way in which they do their leadership and the way in which they support your work by removing barriers, support your career development, solicit your ideas, communicate to you, and recognize your contributions. These are wellness-centered leadership qualities. There's been extensive research on them, and we've been asking our various health systems to report that because we can see real differences when folks are really invested in building strong and capable leaders. I did highlight psychiatry here because they have got the best numbers, but I also want to pay attention that their N is a little bit lower. And so when you look across the board at the higher volume specialties here, you see hospital-based has reported the highest leadership metrics and surgical specialty the lowest. I don't have an answer for that. I have ideas, but I think these are the thought-provoking things that we like to do with our data so we can better understand what's happening. The last bit of data and another eye chart to share with you is a report of physician EHR use outside of work. We asked people specifically how many hours are they spending in the electronic medical record outside of their scheduled patient contact hours. Now, many of you know from various specialties, there will be differences based on the work we do. In a hospital environment, that's different than a medical specialty, say a cardiologist or a pediatrician. They will definitely be spending more time coordinating and documenting care in the EHR. But we know we're all sensitive to that. And there's quite a bit of research showing that the EHR usability, the time we spend in the EHR, has a great impact on burnout. And so when we look at the differences in how people are reporting more than 8 hours, we also know there's some sensitivity to that. And we're examining our data and looking at the groups that are a little more sensitive to changes in the EHR use. So interesting to see the variation in how we practice, but not good to see that a third of our medical specialties and primary care physicians are spending more than 8 hours. So there's a lot more data that we have and that we like to share with our groups, and we will be happy to talk about that in questions. But I first just wanted to talk about what we recommend for people after a survey. Because many people who have done this are very happy to have the information, but then the question is, well, what do you do about it? And we are all about taking action after you do that. So some high-level thoughts on what really matters after doing a survey. First of all, share the findings with everybody that you surveyed. Share it with senior leadership, share it with your wellness committee, share it with your local managers, share it with everyone who was in the survey, and be open and transparent and invite discussion. Sometimes there's a finding there that you're not going to find in the data. Why are female physicians reporting more burnout? That may take a focus group. That may take some other ways to get some qualitative data to better understand the drivers of that. When you've had that discussion, so you're informing your data with qualitative findings, then start to develop a strategy and make sure that with that strategy, you've identified metrics. What are you going to measure? How are you going to know if you're making progress? And so choosing your metrics, whether they're the KPIs, leadership scores, or other things, is incredibly important. And then execute. You're not going to solve this in 1 year. We all know that. This is a multi-year venture. And for me, I think it's a continuous improvement that we all need to do. But when you're executing strategy, we strongly recommend that you remeasure, have a measurement strategy. Some folks are nervous about too many surveys. And so we've been thinking about things like having a lighter survey every other year, but ensuring that we're still following along and letting the people know who answered the survey that you will share the results, you will act on the results. Continuous improvement does a world of good, even if you can't fix everything. And I think areas of focus, and I think we'll end with this so we can have some questions, certainly spoke about leadership when we know the important impact of wellness-centered leaderships, then how that impacts burnout for everybody. And so there's a lot of materials and resources that we can send you and put in the links on how you might think about doing that. I think investing in making your workforce feel valued, that comes in a myriad of ways, recognizing contribution, creating a sense of psychological safety so that everyone can raise their hand and voice their opinion, even if they know it might not be shared by others. Anything you can do in those realms, and we'll talk more about that, makes a big difference. And lastly, and most importantly, burnout may manifest in individuals, but it comes from the system. The system of medicine is incredibly complex and difficult, and all healthcare workers really struggle. So if you're not tackling the local work units, their experience of removing barriers, reducing administrative burden, how can you help them be able to provide care to their fullest extent in their local work environment? This is really important work. This is why well-being and wellness work is tied to clinical leadership, operational leadership, and takes all hands on deck to work on that. So just some parting thoughts on that. And then I'm going to ask Nancy if we have any questions that she'd like to start addressing.
Absolutely. First of all, I want to encourage people to put any questions, comments, or ideas into the Q&A section. We're here to help, but we're also available offline if needed. Jane, before I address the one question that did come up, I just wanted to give one point of reference. On the intent to leave the organization within the next 2 years, as Dr. Fogg said, we are looking for signals if people are contemplating leaving their organization within the next 2 years. What we know from the research is that about 1/3 may act on that intention. So we're not looking at turnover rates of 30%. It would be a third or in that ballpark. Every organization will be different. I do think what's important to note about that is that the intent to leave is not just coming from physicians or others that are planning for retirement, so kind of their glide path or trajectory to leave the organization or practicing medicine. It's really showing itself across all years in practice. So it does give insight to organizations on where they might go back to a certain population, like those 1 to 5 years in practice that express an intent to leave, and make sure that they have been onboarded well, they have a sense of belonging, those sorts of things. So I did want to comment on that. The question that did come up was around the preferred not to answer subset of the demographic. Couple of things to note. We have been watching this particular group demographically since COVID and post-COVID, and we made sure that the responses to that demographic question were rightly aligned so that people could choose the right demographic response, and we do feel that we've hit that mark. But there are individuals that still choose preferred not to answer. Could be for their own confidentiality purposes, although the data we collect is de-identified and we report in aggregate no lower than 6 responses to any particular question. So we make sure we're maintaining confidentiality. What we do know about the preferred not to answer is that typically in most health systems that we work with, it's less than 5% of their demographic. So it's still a small percentage of the overall demographic. And as organizations, as Dr. Fogg pointed out, communicate what they learned from the survey, the action that they're going to take, we have seen the preferred not to answer percentage even drop lower. So there might be a trust piece that comes into that. What we do know and has stayed consistent since measurements starting in COVID and through the years is those that do choose preferred not to answer as their demographic, they always are showing lower levels of reported satisfaction, higher levels of reported burnout, lower levels of feeling valued, higher intent to leave. So we do know as a subset, they're more vulnerable to the issues that we measure in the KPIs. That subset is smaller. And again, because there is no other demographic information, it's somewhat challenging to get at that group in particular. So hopefully that answers that question. And it looks like another one did come in, Jane. Couple
Yes.
questions.
A couple just came in. Well, I will answer the next one and then pass to Nancy. But yes, the organizational biopsy can be obtained by people who are not AMA members. This is part of our mission work. This is a very exciting reason for me to be part of this team, because we know we want to cast a very broad net. So we do gain by getting the data. Absolutely. We can create the benchmarks. We can use the data for research as it's all de-identified. But our number one driver is to help all health systems and practices to participate in creating that initial strategy and thinking about what they're going to do to improve well-being and to measure again. So yes, it is a mission-driven endeavor. So Nancy, we have
You may want to take this one, Jane, as well. Any specific recommendations to connect with physicians? And again, please remember, it's not individual physicians that we're identifying. It may be groups within a demographic, but what are some best approaches to connect or drive kind of some of those changes to burnout?
I think that's an excellent question. And in my previous role, I was the chair of a large service line. And I think nothing replaces human conversation. Nothing replaces my being open to receiving difficult feedback, criticism, concerns, but being present and able to talk to people about the things that really challenge all of us. So if I were back in my role as chair, and I received this information, I would do some drill down. I would try to identify if there are any groups within my service line that are showing higher levels of burnout. I would still make sure I touch everybody, but I would try to identify the hotspots. And I would offer a conversation. Sometimes the best thing you can do is have a one-on-one conversation and just say, please share everything, good and bad, because I really want to learn from you. I want to learn what matters to you and how you experience things. I think that's the first thing that you really need to do. Sometimes there are strategies to bring a group together. In my last organizations, we often had a women's affinity group where female physicians would gather and just talk about what's different for us, have a social moment, share some successes. It was often very upbeat, but it was really a nice opportunity to hear what the ophthalmologist or what the OBGYN or the ER doc, all of us experience in our different realms and how it relates to our gender identity. So I think that's another thing, is creating those sort of focus or affinity groups. The other thing I will add is, in many of our larger health systems, there are structures of leaders, and I might not be the local medical director of the practice, but I really need to work with that local medical director to empower them, to support them, to help them, because their relationship with those that are most burnt out, with those that, as my primary care colleagues would say, we're always walking people off the plank, trying to get them to stay on the ship and not leave. They really need a lot of support. So one of the most powerful things I recall in my last practice was having a forum for the local practice medical directors to talk openly with each other about how they deal with all the burnout around them. And how do they feel, supporting the leaders, giving them tips and ideas, but also acknowledging the very hard work that they do. I think it was lovely to see people learn from each other in that realm and to support each other so that we were all feeling a little more energized to keep up the good work.
Jane,
So
there's an additional question in here specifically about female physicians expressing greater levels of burnout and mitigation strategies. I know you just shared some of those, and maybe you can
yeah,
elaborate. I do want to just share a lot of the research that has been conducted through our work at the AMA, through Dr. Krasinski and our collaborators at Stanford and Mayo. This has been a variation that we have seen in the data over time. And there are some areas that seem to be showing in the data where female physicians may be spending more time with patients in their conversations, in their documentation, how they manage their inbox. So there's some very specific pieces that are showing through not only in the subjective data and the research, but also as health systems start to look at their own internal data coming through their EHR. So again, the
yeah.
administrative burden is an important area. And Jane, you may want to elaborate on some of the inbox or EHR related areas or others with regard to female physicians.
Yeah, I think that's really important, Nancy, you pointed out, and kudos to Dr. Lisa Rotenstein, who's done much of this research. One of the really interesting and compelling ones is looking at a female physician versus a male physician, how many messages they get from their patients, and how much their patients determine how they feel about you, as how you answer those messages. And so, female physicians often feel like there's a little bit more expected, whether it's a longer note, a longer time in the office, or more likely to be answering their email message than a male physician might. So there have been practice differences in the way we approach our work. It's hard to say if that is inherent in how we develop our skills and what we think is important, or if it's what patients expect from us. Certainly, as a female PCP, I can say there can be a different expectation from patients. It's not a bad thing, it's just a different one. So I think we practice differently. I also think it's really important to model leadership and to show that women can be at all levels of leadership. I've certainly seen in a variety of environments, it can really vary. So sometimes I think female physicians are disheartened if they see that everybody in the highest levels of leadership or local leadership isn't representing the composition of their team in terms of gender. So that's another important thing, is representation in leadership.
Maybe Jane, we've struck a chord with regard to how women physicians might practice, and that really is the calling of medicine, is to be interfacing with your patients, et cetera. So I think that's an important comment,
Yeah.
I believe, that we received here. And again, we'll continue to unpack what's in the data so that things can become clearer. I will share that we do know in general with physicians, when we look at issues that might be agitating, compensation can come up. But what we know from the research is that physicians in general, comp is somewhat of a proxy to allow me to provide the care that I've been trained to do and that I want to do. So this important piece about removing the barriers and making sure that work is delegated to the right members of the team, so top of license, top of training kind of care can be rendered. With our APPs, it's not good or bad, but when you see compensation, it tends to be more around salary. But with our physicians, it's around allow me to provide care that I'm trained and capable of providing with a team that can support that as well. Jane, again, I don't know if you want to add to that, but this whole being able to unpack where administrative burden or low value work is showing up, and especially on the back of physicians, is important work that we take on.
I think it really has great impact. And I think there's a lot of themes mixed in here. And I know many of you have been sort of thinking about these issues of how we approach our work. There's always differences amongst every clinician in terms of the expectations they have for their staff, how much they're willing to do below their license. And so I think you can all add into a bit of a stew. A lot of us want to see our patient as our number one priority. And so if the only way to get it done is do it yourself, we tend to do it. And I think that's one of the challenges, is we're trying to do everything in a compressed time frame and with fewer resources. I do want to actually appreciate the question about the APP population, as that's been one that I've done a particular bit of work in terms of thinking about how APPs can work collaboratively with physicians in team-based care. And I think what I find across the board is not every health system or service line or department has really thought through how you have a constructive, collaborative, teaming relationship. And so sometimes APPs are left to kind of figure things out on their own without being part of a team. And so one of the things I do really ask about is, what is your model for practice in your various departments for APPs? How are they partnering up with physicians and other team members? What are their unique responsibilities that they're great at? Where are there opportunities to help recognize their efforts? So I think it's part of being in a team-based care model and making sure that we're really intentional about building that and not just sort of assuming APPs pick up the slack that nobody else can see and without the support that they need. I'm just looking at the questions here.
I'm going to add a comment that maybe you can talk to from two different perspectives, because I think, even Dr. Jabilian's question about how do we support female or all physicians who show up and want to play into their strengths. We do know from research that we've done that inbox messages post-COVID have risen minimally 200% or more. So there is a lot happening just in kind of the workflow of certain areas. And we know that inbox management is a space where many organizations are trying to reduce the work that has to go to physicians. And Jane, maybe you can talk about that, but also coupled with what we've been seeing, at least in more piloted ways, about the impact of AI that really allows all physicians, maybe Dr. Jabilian, female physicians, to have more of that interaction with their patients, because AI is doing some of the documentation lift. But Jane, I don't know if you want to comment on either of those.
Well, I think one thing in our coming year, we're always making iterations and improvements. And so in our coming year, we're going to be adding in some survey questions that specifically get to the impact of AI and well-being. And I think that'll be really, really important, rich data for us. We do hear, Nancy and I meet many, many, many groups, and we often hear that piloting the AI supported scribing, whatever the model may be, has been a success to some degree, or for many people, a big improvement as it reduces documentation time. And there are some studies looking at the actual time, looking at the EHR. I think the thing I also would say is the EHR comes up a lot, and I've spent a lot of time and space in there, and I am a huge, huge advocate of really thinking of the EHR is it is the system in which we work. It's how we do our work. The old days when I started on paper, when messages appeared on my desk, it's now all coming in electronically. And unfortunately, we didn't build those same workflows, those human workflows where my team would have read the message and tried to figure out what they could do before they sent it to me when it was on paper. Now it just comes to me without a filter. I think that's the problem, is that we didn't apply that same logic about team-based care and how we want to support all clinicians to the EHR. We just kind of let it happen passively. So you have these situations where doctors are sometimes getting emailed, when was my last flu shot? Can you add me in the coming week? I have a problem. Instead of that going to the team to resolve that and find a solution for that patient. So I very much like the partnership with informatics. I think informatics are physicians who are highly trained in this area of understanding the capability and possibility of the EHR. And I've certainly seen some great opportunities where we can make the EHR actually work for practice instead of being the drain that it is. Some of it is sometimes just training to things we don't realize are there, but sometimes it's how your practice has built out its application of the EHR and what those human workflows are that are going to support that. So if any of you have an informatician at your practice, bring them a cup of coffee, say hello, and learn what they do. They can really make a huge difference. So I think there's a lot of rich space in that. We also, in our department of PS2, we have a tremendous leader in Dr. Margaret Lozavatsky, who has got a lot of resources available, publicly available on the website, about how we can think of all clinical technology and improve it to be an advantage and not a disadvantage in practice. So we will gladly post those things on our page as well.
want to mention, it wasn't maybe specifically asked, but maybe alluded to. You might recall in kind of the beginning of this conversation today that I mentioned we also survey residency programs across the country. And so we have a data set for residency as well. And I will just say the resident population is very much invested in organizational well-being and their well-being, work-life balance, et cetera. So I do think there is a drumbeat on this body of work coming from the next generation of physicians. And again, not to say that's good or bad, but I think it's important to note that we may have interprofessional areas that we're going to focus on, and we'll have intergenerational areas. But the work of well-being from an organizational perspective is everyone's business.
Yeah.
It doesn't look like
Nancy,
Yep, go
oh,
ahead.
just wanted to add to that because I'm really glad you mentioned that about residents. I feel incredibly optimistic and heartened that we see residency programs and residents themselves, medical students and others, acknowledging that burnout has become a part of healthcare and that we should not let it take hold the way it has. I think the future is brighter when we have our younger minds thinking about how can we change the way in which we practice so we have all the enjoyments of taking care of patients. We feel fully capable of using all of our skills, and we work in a supportive environment. So I think there's a lot of really great work in that space, and I look forward to seeing this generation really help improve a lot of the systems of care that I've seen in my 30 years, unfortunately, decline a bit, or at least make it more difficult to practice. So great to see that energy out there.
Um, Alec, I don't know what your sense is about where we're at. There is a question or a comment, and Dr. Andrew, thank you for your engagement in the Q&A about how we get the information out around the resources. And what I will say is this is mission work for the AMA. And again, we are humbled to be able to do this type of work. We work in the space we talked about today with a lot of healthcare organizations across the country, hoping as well that from an organizational perspective, they can push the assets and resources that we have to frontline physicians. But also we have other ways for all of you and others to stay engaged with us through Steps Forward. And, we have our research out there in the field. So however we can be helpful to help you navigate, we're there to do that. But Alec, I don't know where we're at here. You may want to comment in your summary comments on how people can stay connected to us.
Yeah.
Well, you know what, Nancy? I can certainly do that for you folks. Let's go ahead and talk about what we have coming up for you here at Steps. So thank you both for your time and expertise today. For all our attendees still here, when we conclude, you will see our feedback survey. Please take the time to answer the 2 questions there. Your responses help guide our upcoming programming to deliver webinars you want to see, such as the one you saw today. This recording will be available to review on demand with the link you used to join today and include access to today's slides and recommended resources. Our next webinar this year is a week from today, focused upon resident and fellow well-being. Gain a bigger picture view of the current well-being approaches for residents and fellows with a focus on understanding both the challenges and opportunities within your organization. Our expert speakers will guide you through proven strategies for creating a well-being program from the ground up, as well as tips for strengthening an existing initiative. Whether you are just starting or seeking to build on current efforts, you'll leave with practical steps to foster a supportive, sustainable, and effective environment for physician learners. If you'd like to attend, you can register now with the link in the Resources tab, which will take you to our hub of all our upcoming programming. And finally, if you're looking for something a little more hands-on, a little more in-person from Steps Forward, we would like to invite all attendees to join us for our next Saving Time Practice Innovation Bootcamp in Chicago this September. This 2-day in-person bootcamp is specifically designed for clinical and operational change agents looking to eliminate unnecessary work and free up more time to focus on patient care. And I believe Dr. Fogg will be on staff this September, although I don't want to say that if that's wrong. She's nodding, so I believe yes. So you will have time to talk with her and talk shop. If you're interested in attending, you can scan the code on the slide or follow the link in the Resources tab. For any additional resources that you would need to support physicians and staff, including those on organizational biopsy or the Joint Medicine Recognition Program, please visit the American Medical Association website, stepsforward.org, or any of the links in the Resources tab. We thank you all so much for joining us, and We hope to see you again soon.